Good afternoon, everybody. Yes, I'm Priya Bari. I work in pharmacovigilance, specifically in the service for epidemiology, where we actually look at increasing evidence for decision making, obviously to support the work of the PRAC. So I'm here to offer you a complementary view on a case study, which we have done in the context of the project Patrick has already briefly mentioned this morning about how we measure impact of pharmacovigilance. And the engagement process is a major part of this work. And we want to measure, this is actually really useful and how can we optimize purely from the perspective of taking the best evidence-based decision, how can we optimize that process? So the objective of that study, which complements the work you have heard from all EMA colleagues this morning, was to analyze the content with a view on how we can develop good practice for the future and enable that we have a systematic inflow of contributions which are optimized for each of the products. We had already this morning a comment about how can we optimize, given the safety concern, given the product, how can we optimize this engagement? And this case study is done with that view. So we had actually 3 mechanisms of involving patients, as we have heard this morning already. We had a written consultation right after the start of the referral, and then we had 2 face-to-face interactions. The public hearing as a new tool, ever first public hearing, and then a dedicated meeting with patient representatives, healthcare professionals from various specialties, which had a gap, I think, from only 1 week. Is it right, Sabine? It was very close. Here, this case study really focused on this face-to-face interactions, which we expect is actually gives us a huge opportunity to really sit together and discuss. And the question is, were these 2 engagement mechanisms, did they build up one on each other? Were they complementary? Were they overlapping? Was it an efficient use? How can we optimize these 2 tools for the future? Now, as you may remember, think you want to optimize, for example, your food intake over the day together with your family. And you would have a first meeting where you discuss about having breakfast, having lunch, having dinner. And you could discuss many things about that, and you might come to the conclusion, next day we have another meeting and we focus on the dinner because that's the time when we all meet together. Okay, and that's the most important meal for the family. But you may imagine that a lot of things in the dinner discussion would come back about, yes, but but we'll have to dinner, that will be influenced by what I can have for lunch, and I'm eating in the canteen and somebody else eats outside next to the desk while working, So you would have a lot of overlapping issues, even though your questions might be very specific on something. So the question is, how do you actually analyze a discussion? I mean, I had never done that. So here, first time experience, I was wondering, how could I actually compare this? The questions are similar, but also different. The topic is the same, but how would you actually analyze? So you need to come up with themes. The themes could be around, what kind of nutrients, what kind of timing, can we have an extra dessert, yes or no? And all along these themes, then you can sort of thread together what was mentioned in which meeting, in which discussion, to which extent. And so basically, I needed a tool to analyze that and to compare the 2 interventions and also to compare the stakeholders and their contributions. So that first step was that tool. And because we learned, as explained this morning already, implementation was the key problem in 2014, from the 2014 referral. The implementation was not as we wanted it to be. So it was quite obvious that the implementation science might maybe provide us with a good structure to analyze the input, because implementation is what we want to improve. So based on a couple of, here you can see the background here, I came up with 6 criteria and a number of sub-themes to get really the granularity, but I'm focusing here just on the 6 criteria. We need to learn about the appropriateness of the risk minimization measure to actually reduce the harm, which means, like, for example, people rightly said, well, we need an annual review of the patient every year. But what do we know about that annual review would ultimately lead to the reduction of exposure? Will it, maybe these are already the patients who cannot have an alternative. I mean, this is like the appropriateness from a purely from the viewpoint of the physiology and the mechanism of the medicine, can actually, has it the power to reduce, from the epidemiology of the disease, has that risk minimization measure the power to reduce harm? Then the next point is the acceptability, because everything we do on the safety side will impact on the access to the medicine. And is that actually acceptable? Because easily we could just say we withdraw medicines from the market, but then we also withdraw the benefits. So we need to discuss these trade-offs. The third theme is around the audience-tailored approach, and we have already discussed a lot this morning. The typical patient does not exist. So how can we tailor for each patient in their individuality? Then we have the compatibility of the risk minimization measure with structures and resources, which is different from, is it implementable with the healthcare process? So for example, you can have a measure. I'm giving you an example from a medicine some many years ago. We needed to have visual field testing for the eyes. From a process point of view, that's very easy. You need to have a mechanism in place that every year the patient gets a reminder letter, you need to have that testing. Fair enough. That could be organized. The problem came that in some country, the place where they can do it is too far away for them to reach. So you have then a question of resource. So there are two different concepts. So that's why here they're distinguished. And then obviously the time-bound requirements to make an impact immediately, and sustainability. So what were the outcomes? Well, alongside analyzing alongst this grid, and a lot of things we have already also seen from other analysis this morning, there was overall an agreement that the access to the medicine is needed. Nobody was doubting that there are patients who need this and nothing else. There was also a majority agreement that this is an informed choice of the female patient. I mean, nobody was, only little hints, but nobody was really asking for, there cannot be a choice for the woman. You know, that was not discussed. So that was very important for the decision maker, obviously, to know that there is this consensus around a very fundamental process about patient autonomy. Then what we could clearly see, however, that there is pretty much a lack of coordination of healthcare. I mean, this was literally expressed by the healthcare professionals. And there was also a lack of how could the risk minimization measures really be incorporated in the process. And I think Raymond this morning was just giving the example. I think the pharmacists were quite solution-oriented and said, if we get the card, we can use that as a prompter to talk. But that was much more difficult for all the other healthcare professionals. Like there was a lot of discussion about the GP and how could you refer to the specialist, but then can we refer, and how is this triggered, and what can the nurse role play, and all these things is much more complex. And this could not be disentangled in that public hearing. Obviously, it was also not the purpose, but it came up, something we could identify through that content analysis. There were a lot of risk minimization proposals, which were all completely plausible expectations. But as I just said, there was not so much evidence on how would they really reduce the harm. I mean, it's expected they will reduce, but we have not yet the evidence that these measures will actually, when properly implemented, also lead to the outcome we wish, you know, because we don't know who is precisely exposed, who could be channeled to something else, but then what has that something else for an impact, or will people just not use the medicine altogether because they are scared, or all these sort of things. We don't yet have enough evidence. So the discussion was very much based on expectations. There was actually also very little convergence on the practicality of the implementation. That was, again, maybe outside the scope, obviously. I mean, but it's something where we have to think from an implementation viewpoint that we still have lack of impact in these areas. Then we had a good discussion on tool preferences, including the pictogram, but again, we have still conflicting evidence here. And that's not anybody's fault, it's just an observation. And so the preliminary conclusions, now this is my last slide, Albert, to calm you down. So I think from our perspective as regulators, the engagement was really important, successful, and really useful. It made a huge impact on the decision making. We communicated, I think it could also see that we need to communicate more with the public about the rationales and the dilemmas of regulatory decision making. So the dilemma, for example, is that trade-off between access and risk mitigation. Where do we stand here? That is one of the dilemmas. There are many others. And I think honesty really increases that trust building we have talked about this morning. Mutual understanding, mutual adoption of knowledge. So listen to what we hear. I think we have talked a lot this morning about the public hearing is there to listen. But actually with this content analysis, I found it as interesting to see what we could not hear. Where were still the gaps? And I think the gaps were in that researchers do not yet give us all the evidence we need in order to, for all of us, for all stakeholders to have a more informed discussion, but also the agreement, how we can things do in practice, and the leadership, who will ultimately take the leadership to implement. I mean, I think, yes, regulators take the leadership to provide for a framework, but then who is actually implementing and who is finally waving the flag to do it and does it and brings it to the end. Then we have the, so then the last three bullets show where maybe we can use the content analysis in a more future-looking way. So maybe that toolkit with this 21 also sub points and so on can help us to maybe ask sometimes more specific questions. We had very good questions, but maybe some questions could be added to which look more into implementation and practical solution. Now I'm talking as a pharmacoepidemiologist. I really believe that pharmacoepidemiology, which is the science to look between medicine exposure and the causality with an outcome and health outcome, we should connect that better with health service research, because obviously a lot of things happen until a patient gets exposed, and a lot of things happen until a negative health outcome or a positive one, depending on, occurs. And I think we have to marry these two sciences together better to give us the evidence we need. And then the question is for us as regulators, what can we do as catalysts and support implementation further, and what needs to happen in addition to what's happening already. With that, I close my presentation and look very much forward to the discussion we hopefully can still have. Thank you.